Greetings, everyone. Welcome. It's wonderful to see so many people from across the globe joining us in today's session. So welcome to today's webinar, Communicating with Emotional Competence, Making a Difference to Patients, Colleagues and Professionals' Own Wellbeing. This event is brought to you by the Global Health Network and its Knowledge Hub, Connect, a hub for health workers and field workers involved in research. I'm Jan Fisher, Research Enrichment Manager at the Public and Community Engagement Group at the Oxford University Clinical Research Unit in Vietnam, and also coordinator of the Connect website. I'm delighted to be joined today by our wonderful speakers, iCARE-Haaland, International Trainer and Researcher on Communications and Emotional Competence and Social Scientist from the University of Oslo in Norway. Mwanamvua Boga, Pediatric Nurse Manager and Lead Trainer from the Kenya Medical Research Institute, Wellcome Trust Research Program in Kenya. Dr. Florence Marilla, Consultant Neonatologist and Newborn Unit Head at Kenyatta National Hospital, Kenya, and Senior Lecturer in the Department of Pediatrics and Child Health, University of Nairobi in Kenya. To Nancy Mburu, Pediatric Nurse Manager and Trainer at Keregoya Hospital in Kenya. Dr. Isra Hassan, Consultant Anaesthetist at the University College of London Hospital. And Dr. Thomas Kitchen, Consultant Anaesthetist, Lecturer at Cardiff Medical School and Director of Canopy in Wales, and the support of the Global Health Network team. Communication is a fundamental element to any form of human interaction. When it's occurring within the context of a stressful health intervention, effective and empathetic communication plays a crucial role in healthcare interactions, impacting patient experiences and outcomes and creating a harmonious work environment. In this extended webinar, we will explore the vital role of emotional competence in communication, introduce the iCARE-Haaland model, an intensive training model focused on establishing healthcare professionals, enable healthcare professionals to recognise and manage emotions, to be able to communicate well with patients and colleagues, and in so doing, to take care of their own health and wellbeing. Hear from healthcare practitioners who have utilised and benefited from the iCARE-Haaland training, learn of practical strategies to become more empathetic and effective communicators utilising active listening techniques, empathy building practices and managing emotions effectively in challenging situations. This webinar session will last 1.5 hours. We have 6 fantastic speakers and we will allow plenty of time for your questions during the event. Before we begin, I just want to run through some housekeeping quickly. Firstly, this session is being recorded and the recording will be shared in the coming weeks on the Global Health Network platform and the Connect site, so you can review and you can share the materials. These materials can be found using the link that's being shared in the chat at the moment. This webinar will be held in English. However, if you would like access to another language, then please go to down the bottom of your screen, there is access to translation, text translation that you can choose. So just navigate down to that section. Please use the chat feature for introduction or to report any technical issues you might be experiencing, and the Global Health Network team will aim to assist you with these. To interact with the panel, please use the Q&A feature to post your questions and your comments, and you may do so anonymously. Due to the number of participants, your video and microphone have been disabled. There may be an opportunity at the end of the session to ask questions directly, but please raise your hand and we will enable your microphone. So we have dedicated time allocated for Q&A, so we'll try to get through as many questions as possible. If we don't have time for all of your questions, we will compile and address them after the session, and these will be available on the Connect website as well. So, to start our session, firstly, I'd like to welcome you all to our webinar and to introduce you to our first speakers of the session. Firstly, to iCARE-Haaland, an international trainer and researcher in communication and emotional competence and a social scientist. She has developed and implemented the iCARE-Haaland training model in collaboration with doctors and nurses in 9 countries. Her focus in recent years has been communication and emotional competence skills training for health personnel. The iCARE-Haaland model uses reflective learning over time to inspire deep and sustainable learning. Anna has worked in 30 countries for research institutes, universities and international organisations in social science research, education and curriculum development, journalism, professional development training and photography. And Wanamvua Boga, a paediatric nurse manager and lead trainer and researcher with over 20 years experience in acute paediatric nursing and clinical research practice in Kenya. Her work includes care of critically ill children, nursing management, and administrative responsibilities and capacity building. Over the last 15 years, she's extensively been involved in training health providers and research staff at hospitals and universities in Kenya and the Gambia on communication skills and emotional management using reflective practice and experience-based learning methods. Her commitment to strengthening respectful care and professional wellbeing among health professionals has seen her train over 500 health professionals, researchers and managers and present her work at several national and international conferences. So before we start and welcome Anna and Wana to speak to us, just a reminder that throughout the webinar, I encourage you to add your questions to the Q&A box and our speakers will address these later in the webinar as much as they're able. So we invite Anna and Wana, who will explore emotional competence in the healthcare context and introduce the features of the iCARE-Haaland model, which is available to access via the Connect website.
Thank you very much, Jo, for that lovely introduction. Good morning, good afternoon, good evening, colleagues and friends from all over the world. I see in the chat that you are from many of the countries that I have worked in, and that is really, really lovely. So I have a question to you. Do you think that learning about better care has anything to do with emotions? Can we learn better care when learning about emotions? Our answer to that is a resounding yes. And the model we introduced to you today is an empowerment tool that people need but were never taught. The healthcare professionals we trained in 10 countries said that management of emotions was the most important skill they gained, and they had not known that they needed this skill. So this is over a number of years, which we'll get back to. So communicating and managing emotions well make a huge difference in people's lives and well-being, including, but not limited to, reducing conflict and burnout. Many healthcare providers have not been taught to recognize what they are feeling and how to talk about these emotions. They have not been taught how to be friends with emotions and use them, rather than seeing them as a weakness to be denied or rooted out or ignored. They've not been taught how to recognize, respect, and respond to emotions in others. So using the methods that we'll show you here today does take time, but learning these skills is possible using this model. So with this introduction, let me turn over to Wana, who is going to show us the little bit more. Luis, 2 slides more. Wana will take us through through the context where these skills are needed.
Okay, thank you, Anna. And to our participants, good morning, good afternoon, good evening. So let's look at the context. So what are some of the problems in the healthcare system? And why do health professionals need skills on how to communicate and manage emotions? Next slide. So I think you will all agree with me that health workers work under very stressful situations with so many emotional challenges to being human. And these emotions influence our communication behaviors, the quality of care we give to our patients, as well as our overall well-being. Next slide. And there is a lot of evidence to show that we as health workers suffer from very high levels of stress in our work. And this is a recent systematic review during the COVID period that almost showed that almost half of health workers were stressed. And then we looked at this other survey that looked at a mixed group of professionals, including health workers. And this survey showed that health workers reported very high levels of stress compared to other professionals. So as health workers, our work subject us to a lot of stress on a day-to-day basis. Next. So I think what we need to acknowledge is that emotions are a natural part of being ill and of treating ill patients. So we as health workers, we go through fear, insecurity, anger in our job, and our patients also experience the same. And one thing is we need to learn how to manage these emotions and our own and our patients' emotions. And often emotional care impacts patient outcome. And often when patients come to us, what matters to them is how we meet their emotional needs. And many of our patients' complaints are around how they were handled, not how they were given medicine or but how they were handled by the health workers. And often you see that in our profession, in medicine, in nursing, we learn a lot on technical skills, but when it comes to the skills of care, that's not really learned a lot in our curriculum. Next. So I just want to pause here and ask the participants on the call, has any of you have been trained on how to recognize and manage emotions, your own patients' emotions, and how to take care of your own well-being? If there is anybody in the call who has had a privilege to be trained on emotional competence, just put a yes on the chat. We just want to see how many of us have been able to learn skills on how to recognize our own emotions and patients' emotions and take care of our own well-being. So I can see a few yes in there, which is very wonderful. But what I want to say is that most of the participants that I have trained in Kenya, none of them had ever been trained on emotional competence. And neither did they know that managing emotions is something that can be learned. Next slide. So I think as a result of the emotional challenges that we go through, we suffer a lot of challenges related to emotions, including burnout, mental problems, quitting our profession very early, and also a prevalence of suicide among health workers is also quite very common. But all this is because of the ability of us not to manage the many emotional challenges that we face in our work. Next slide. So if we look at the prevalence of burnout among healthcare personnel, it's quite very alarming. And the WHO recently recognized burnout as a medical condition. And the prevalence is quite very high in sub-Saharan Africa. Or on this systematic review showed that health professionals in sub-Saharan Africa have very high prevalence of burnout, and particularly nurses. And this is all because of the long-term emotional demanding work that we do, which affects our mental and physical health, affects the way we relate with the patients, the way we relate with each other, our job performance, our career satisfaction. And what is very common is there's limited interventions on how to cope, interventions to promote professional well-being and prevention and coping with burnout among health workers. Next slide. So these are questions that we ask our participants in the training. How do emotions affect the way you communicate with patients and colleagues? And I just want everybody to take a step to reflect when they're emotional, how do they communicate with their patients or with their colleagues? And next. Next again. So these are some of the responses from our participants. They say, one of them said that when overwhelmed by work, sometimes I find myself shouting even when asked a simple question. And when people suddenly treat me with no respect, I frequently react spontaneously, do not control myself, and just stop communicating with such people. So this shows how emotions really affect the way we relate with our patients and even with our colleagues. Next slide. So as a result, there's so many reports globally on disrespectful care, and it's all about how we relate with our patients. So here in Kenya, there are quite a number of reports, and I think majority of you may be aware about the Francis report in the NHS. And all these reports, what they are recommending is the need to strengthen kindness among health workers in the way they relate with their patients. Next slide. So I think an important reason for the low ability to handle the many emotional challenges that we face as health workers is the lack of awareness and skills to recognize and manage our emotions and patients' emotions. So emotional competence is not taught in our medical and nursing school. And studies show that there's profound need to bridge the gap between medical and emotional aspects of care. So we are very good in our technical work, but when it comes to how to handle our patients' emotions is quite a challenge. So there is need to teach emotional management to healthcare professionals so that they can do their work well and enjoy what they do. Next slide. There's very good evidence to show that good communication has value in the way we relate with our patients. So it does create safe work environment, lessens patients' distress and anxiety and depression, strengthens patient-centered care and satisfaction, and enhances providers' confidence and job satisfaction. And also it helps prevent staff burnout. And the opposite is very true. When we don't relate well with our patients, there are so many detrimental effects that happen to our patients as well as our own self. Because when you communicate in a harsh way the whole day, by the time you go home, you are burnt out and you don't feel that you are satisfied with what you have done. Next slide. So we need strategies to build these essential competencies on communication skills and emotional competency skills for our health workers. So by the time they are leaving their profession, they're leaving their training, they are fully equipped with both technical skills and also skills to care well for their patients. So at this point, I want to welcome Anna to take us through the model of training that we are using to train our health workers on communication and emotional competence. Welcome, Anna.
Thank you very much, Mona. I unmute myself, yes. Thank you very much for that very, very comprehensive, good overview of the challenges that the skills we are working on are aimed to deal with. Next. So I'd like to take you through why and how I built this model, how it works and why it works that way. Next. So working in healthcare in Asia, Africa, and Europe for decades, I discovered that there was a lack of practical learning models and tools. Tools to train health providers to strengthen self-awareness about communication and emotions, to build their emotional intelligence, and to reflect critically on how they communicate with and relate to others. There was no model that I found that described using self-observation and reflection in action and on action to get insight into how to learn systematically and gradually, to build reflective skills, and to recognize and manage emotions in a safe way. So, and I also saw the price that the people, the colleagues were paying for not having this knowledge and these skills. Next. please, if any of you have knowledge of models, please put them on the chat. We would really like to hear about models that deal with these issues. So I started to build a iCARE-Haaland model to communicate with awareness and emotional competence in collaboration with doctors, nurses, researchers, and managers. This is from Šiauliai, Lithuania, at a tuberculosis hospital. This is where we started in 2006. And then worked in several other countries, as you can see here, in Eastern Europe, and Africa, and later in the UK. And Moana joined the work in 2009. So far, we've trained more than 400 people in 10 countries. Next. The key features of this model is that training empowers healthcare professionals to strengthen their self-awareness, to manage emotions with empathy and confidence, and to increase their capacity to take responsibility for respectful interactions. This creates the basis for the trust that good care requires. And here we have, I have put links here to part A, to the background about the model. And there are links throughout this presentation that you can go in and click on later. Next. So the model is about reflective, guided learning over time. It takes time to change communication patterns because it's taken us a long time to get them, the ones that we have. So evaluation showed, as I said in the beginning, that learning to manage emotions was the most important skill they gained, and they had not known that they needed it. If you want to see Moana and me presenting the model in a YouTube video, here's the link. Next. Our training aim is to strengthen awareness of the effects of one's own communication habits on other people. Not only how are you communicating, but what happens on the other side. So participants discover how they communicate, they reflect on it, and then they set new goals once they see what the issues are. New goals to communicate with awareness and respect for emotions. Next. In other words, emotional competence. This can turn frustration and emotional exhaustion into understanding and emotional connection. And it is this beautiful emotional connection that gives healthcare providers so much energy and really can help to balance from all the emotional labor that Moana was talking about. The connection, the emotional connection, when you know how to work with it, this really has an impact. And it also often results in better care, better outcome. Next. So let me give you an overview of the training, of the reflective learning process. It takes 6 to 9 months. Some have done it shorter, but the longer, the more profound the learning. The first phase is about discovering your own communication habits. You observe yourself and reflect on your own, it's on-the-job learning. And this is without the course, this is just tasks that you do on your own to strengthen your awareness and discover what the problems are. Phase 2, you come to a workshop for 3 to 5 days, and the observations you've done in the first phase, they are the basis for linking to theory and practice using experience-based learning and reflective practice together in the workshop. Phase 3, now the skills go into practice. The new skills, you practice them in your work, and it's information and informed reflection in your daily routine to strengthen self-awareness. Phase 4 is the links will not be shared on the chat now. We'll share the links afterwards, and you will get this presentation, because sharing the links now will interrupt the flow of what we are doing. So, but you'll all have them. So the 4th phase is a follow-up workshop, which summarizes and anchors the learning to daily challenges. And this is a focus on difficult emotions, challenging emotions, because this is when they are ready to learn them. Next. What we are doing is based on literature and based on experience. the evidence from the literature on communication skills training shows that developing professional identity and core human values requires training conducted over time using experiential learning methods, critical reflection, and supportive group processes. And the iCARE-Haaland model includes all of these features and many more. Next. Next, yeah. So let me take you through some of the methods that make the model work. The key methods are awareness training and reflection in and on action. Yes, next. The course is voluntary because you cannot teach somebody who doesn't want to learn about communication. You cannot teach them. So you have to want to learn. And people join because they've seen that they need to learn how to communicate better, and they really want to do so. Next. The most important skill is awareness, strengthening self-awareness throughout and afterwards. It's awareness about how you communicate with others, the effect your communication has on others, and how emotions affect how you communicate. Next. Now, I'll spend a bit of time on this slide because this is about how the process works. The process starts with the decision that you want to communicate better and that you decide you need to learn, and it's a voluntary decision. At work, you do self-observation over time. You have one task a week over 3 months, and you note what you're learning. And while you're doing this, you may discover, and many people discover, that my behavior hurt others. For example, we say you put on these lovely antennas and you say, okay, I'm going into the next meeting now. I'm going to notice what's going on. And you go in and you see that you're listening to this patient, but your thoughts are completely somewhere else. And you can see that this hurts the patient. The patient stops talking and is not with you. And then you ask, you reflect, do I want this? Once you've seen it for a whole week, do I want this? And all of our participants say, no, I don't want this. I don't want to hurt others. Of course I don't. I'm a carer. So what a question. But when you discover that this is actually what you do, you have a reaction, and then you say, I need to do something differently. So you learn in the workshop skills to recognize and manage emotions, to recognize them first and to manage them in relationships. When you experience that your new skills work better, you decide, I am changing. This is much more fun when things are working well. And the whole process triggers your inner motivation to change, and this is sustainable. When you see that you're working better, why should you go back to your old methods? Next. So the essence, let me speak a little bit about these methods, the essence of the learning here, reflection in action. It's about thinking while you're doing it. So we say you put on your antenna, you go into this conversation with the patient, and and you're experiencing what you're doing while you're doing it. It happens during the event, during the conversation with this patient. And again, you see that you're not there. Your mind is somewhere else, and you don't really relate well to the patient, and the patient notices and stops talking. It makes you aware of the emotional reactions, both your own and the other person's. So when you do this is a really powerful method. And when you do this together with reflection on action, which is, by the end of the day, what did I learn today? I was listening badly 3 or 4 times. This is a pattern. You think back on what you were doing. And you reflect and you understand what has taken place after the event. And after the event, in the evening, the awareness of the emotional reactions is much more limited and often forgotten. So you need these two in parallel. First, reflection in action, and then on action. Next. Because emotions, as I'm sure you have seen, emotions are contagious. They can lead to automatic emotional reactions and behavior. I really like this here, how emotions are contagious down to the poor little teddy bear. Next. So to reflect well, you need to learn to take a step back from your automatic reactions. And stepping back helps break the cycle of automatic emotional reactions and behavior, and much more. So this is, if I should pull out one thing from the course that you need to learn, it's learning to recognize emotions, take a step back before you act. So the awareness training and emotional competence is very much needed here. Next. So why does reflection in and on action lead to insights, deep learning, and change? Some of the main reasons are that once you start the discovery phase, you start observing yourself. And this learning is safe emotionally because you own and control what you want to share. If you discover that, oh my goodness, my communication is terrible, I'm really ashamed of this, you don't need to share it with others. But you can. And here comes the interactive reflection in the workshops, where trainers explore and invite sharing, and they do not judge. And here you find that there are many more who are doing horrible things, or things that they didn't know that they were working that way. And you share with them, and by doing that, you learn why you're doing it, and you learn how to do it differently, and then you can get on. Relevance is another key thing here. The observation examples are from their own work, and when they are in the course, they recognize everything that we're talking about. It's not theory from some other country, it is from their own work. Then informed reflection. In the third stage, the participants, they own their new skills. They practice them with patients and colleagues and at home, and they often get very positive feedback. I wish I had time to tell you stories, and one or two from what happens at home when they're using these skills. The sequence of these tasks that are built up very carefully, it gradually deepens insight and confidence and the new habits. And if you want to see how this works, use this one, an example of changing practice on respect in Kenya. Next. So finally, a few results. We see similar trends of changes in all the countries where we have worked. We see there's strengthened awareness in all the work. We see improved relationship with patients and colleagues. We see that they recognize emotions, step back from wanting to blame, and take responsibility to communicate better. They treat patients as persons, they don't judge. There are fewer conflicts, there's reduced stress and burnout, and so many report increased job satisfaction. This is all from self-report from 9 countries. But in Kenya, managers have confirmed the provider's assessment of change, and also an external evaluation confirmed these results. So we're pretty confident that this is exactly what is happening. Next. In Wales, the trainee doctor said, this training is changing our mindsets. The training has changed my mindset and my outlook on so much. I now feel more relaxed and happy, honestly. When I signed up, I was thinking of leaving medicine. The work is still the same now. It's just how I look at it that has changed. I don't feel stressed or demotivated. I'm surprised at how much effect the training has had. So thanks very much. This is what I had to say now. We have some more results, which we'll share with you at the end of the session. So if you put the next slide, please. Now we'll hear from our guests, and I think we turn over to Joan.
Thank you very much for that introduction. and a great understanding of the current context. Many of our health professionals online, I'm sure, are nodding as they're listening to what you've both shared in terms of their own experiences and a wonderful introduction to the iCARE-Haaland model. We're now going to invite our next speakers to share about their experiences of integrating their learnings within their work and in their interactions with colleagues and patients. So firstly, I'd like to welcome Dr. Florence Marilla, consultant neonatologist and newborn unit head at Kenyatta National Hospital and senior lecturer in the Department of Pediatrics and Child Health, University of Nairobi in Kenya. Dr. Florence has consulted extensively with international organisations, contributed to publications, and held significant roles on various medical boards and committees related to infant mortality. In 2018, she was awarded the Paediatrician Hero Award. Dr. Florence will share about the importance of this course for medical doctors and nurses, and is working to implement the training for all of her staff. So welcome, Dr. Florence.
Good afternoon. I participated in this training last year. And after the iCARE training, I am better able to work with emotional intelligence in my unit. I take time to be considerate of the emotions of my colleagues. I am more cognizant of the fact that we are short-staffed and so the staff are overworked, and that this may cause tempers to flare. I'm also aware of the fact that many of my colleagues are suffering from conditions that may have risen from this overwork. So these days, I more easily step back and analyze the situation before I speak, and I'm better able to handle difficult situations with calmness. My staff also handle patients differently than before. They are more aware that the mothers are very anxious about their tiny preterms, and so they handle them more gently and patiently than before. They stop to appraise mothers of the condition of their babies and the treatment that their babies are being given. When mothers are rude to my staff, they step back and will themselves not to take offense, and sometimes they keep quiet or give a calm reply. In my unit, we now have more frequent family conferences at which we discuss the management and prognosis of our very sick patients so that we can allay the anxiety of the mothers and involve them in decision-making and feeling that they're involved. There has been a change in the well-being of the staff. They now understand each other better, especially each other's difficulties and shortcomings, and so are better able to work together as a team. There is job satisfaction because they feel that they handle patients better. And some of the patients have actually stated, when questioned, that they feel that they are listened to and are given information about their babies, and that they less frequently get ignored or receive rude replies from the nurses. I would like to train the rest of my staff in this iCARE training. We trained several of them, about 6 of them. Now we'd like to train the remaining 80 of them. The reason is that I feel that some of my colleagues don't understand themselves, and they need to understand themselves. And I know that the training helps one to understand themselves through the reflection time and self-analysis of how one communicates and the effects on both colleagues and patients. Some colleagues struggle to handle mothers who have lost their babies, and they need these skills to help them manage such cases. The skills will promote teamwork and improve the care of our babies. Together, with the nurses. We are more aggressively addressing the issue of having more nurses so as to reduce the burden of overwork that has led to burnout in quite a number of nurses. Some are hypertensive, some are just stressed, and so they often take time off. And so, and when they take time off, now we have even more overwork because we have fewer nurses left. And so we are working on it more aggressively because we are aware that we are more self-aware, and we know that we need to rest and be in a good rested state so as to deal better with our patients. Thank you for listening. Good afternoon.
Thank you, Dr. Florence. Just a reminder, if as we're listening to the speakers, you have any questions that you'd like to direct to any of them, please do add them to the Q&A and we will try and answer those later. So now to welcome Nancy Mabura. Nancy is a paediatric and newborn nurse manager and trainer in both clinical areas and emotional competence and communications training at Keregoya Hospital in Kenya. Nancy will share how the training has strengthened the ability of her staff to communicate well with patients and with colleagues. Welcome, Nancy.
Thank you. Hello, everyone. This is one course that have really transformed me and my colleagues. And the holistic approach of this course have really transformed me as a person and even my colleagues. So as we work, we are working with awareness. As Dr. Florence has said, we are working with awareness. We've been able to build up a healthy relationship between the colleagues, between the relatives, how we handle the relatives, and even how we handle our children back at home. And this course have helped us to really understand ourselves, the impact of our communication with each other. One thing that I really appreciate of this course is the reflective phase, because I did it sincerely. I was sincere to myself, and I encouraged my colleagues that I lead in my department to reflect truly, to look at how we communicate and the effect of the same. And because of that, we discovered that our communication can do a lot of good and can help mothers to take care of their babies as they go through the trying times of their with their sick babies. And this has reduced conflict in my department. It has made my department to be rated as #1 implementer of the family-centered care. Patients are coming out asking for referrals from other hospitals to come to be taken care of in our department. And this has also improved the work relationship with colleagues, and it has really promoted healthy communication in our working area. Also, it really helped me to understand my own personal emotions, that today I'm able to recognize my emotions, early signs of burnout, and being able to ask for time out to recover or to recharge. And this have been very, very helpful. Simply because we were never taught this in a medical school. No one ever taught us that. And so this course have been very fundamental in the change that we are experiencing today. There has been remarkable productivity in the way we take care of our babies from the time we land. And actually, I really recommend that everyone who is working with the patients, everyone from the management to the least staff working with the patient should go through this course. It's one course that has really transformed me. Thank you.
Thank you very much for that, Nancy. It's quite clear that it's been had a huge impact, both personally and also you've observed through your colleagues. I'd like to introduce our next speaker. Our next speaker, unfortunately, is not able to join us live, has been called away to surgery. However, I would like to introduce Dr. Isra Hassan, consultant anaesthetist and perioperative care at University College Hospital and trainer on perioperative medicine, at London UCLH in the UK. Dr. Hassan has pre-recorded to share with us how she uses the skills in her daily work and how she also trains junior doctors. So thank you.
Joan, can I just say one word here?
Certainly,
about
yes.
Isra and Thomas, who will also not be able to join, are two anesthetists that were part of the group in Cardiff that we trained in 2016 and 2017, and they are doing great work on this. They are continuing the work in their present hospitals. So, without further ado, let's hear from them.
Thank you.
Isra.
Yes.
Welcome. Very nice to see you. And you joined a program for junior doctors on communication and resilience training in 2016. And after the 6 months program, you said other people need to learn these skills, and you took the initiative so that we could continue the program, and you became a trainer. Could you say a bit about why that was and what it is about this training that has helped you in your work?
Yeah, so I think up to that point in my training, especially back in 2015, 2016, resilience and well-being was just coming into the forum of conversation. And I was very aware that there was an awareness that we needed to have it, but what was lacking was solutions to addressing the need. And I think this program for me was very unique in providing solutions and looking at your communication skills and embedding them in your everyday practice. And the reason why I felt like this had to be shared is that, as I said, there was an unmet need in the domain, and the things that were coming out were just a one-day course that felt very much like a tick box exercise and not very genuine or authentic. And this program, for myself, also my colleagues, it changed their practice and their professional but also personal well-being and resilience. So I felt like it's something that had to be shared, that there are problems but there are solutions, and this was one way of dealing with it in our everyday practice.
Mm-hmm. Great. And you said it was the fact that it went over time that made a difference.
Yeah, absolutely. So I think with the workshops and going through your communication skills and in action reflection, it wasn't just a moment in time. It was embedding in your continual professional development, from a junior registrar to a senior registrar to a consultant to a manager. I'm continually learning this skill, and I don't feel like it is done. And it's a classic quality improvement methodology, which we're as clinicians told to do. You continue improving on the skills you've learned, reflecting and changing. And I felt like this program is the epitome of those skills that we're taught to do.
Mm-hmm. Great. Yeah. And you are now training your own junior doctors, and you have become a role model, and probably also a role model about how you manage your emotions. Could you say a little bit about how that functions with your junior doctors, how you train them and how you work with emotions?
Yes. Well, I did it from a role model. I mean, I think I would like to think so, but I think we're talking to my trainees and the fellows, and actually being there myself 3 years ago, you do look at the people in power or your leaders as role models, good or bad. So there are times where it's more evident, you are aware of the role models you don't want to be like, and they often stick out why you don't want to be like them. I think talking to my trainees, what's important is that the field that I'm in, perioperative medicine, is very much a centerfold of being involved in lots of different specialties. So we're definitely partnered with surgeons, anaesthetists, medics, always put the patient at the centerfold, and we follow the patient through the journey. I think that's why that's important with these skills, is because you're dealing with patients in different states, elective, emergency, often dealing with cancer where there's heightened emotions. But also with the team, there's often things that don't go to plan, and there's lots of lines of communication that may be missed, again, leading to different kinds of emotions. And I think that the reason why I believe in this program, I try to teach it to my trainees, is that emotions can change outcomes in a favorable way, but also not favorable if you don't recognize them and use them. So it's really important to be aware of your environment, who you're dealing with, and having that helicopter view, and the importance of working on yourself, also being emotionally intelligent to the environment you're working with, is pivotal to our everyday job in order to have good satisfaction in work, well-being, sustainability. But I think they all lead itself to being a role model and educator. So I see them as vital skills to have. I am always learning. I will always continue to learn. I am definitely not perfect. There are days where I do feel more vulnerable. So if I'm tired, I do 7 days on call in a row. I know that I'm going to be on day 7 more aware of my situation, that I may be tired, I might be more snappy. So just having that awareness that I'm going to be vulnerable, I think is really important. And also from the other point of view, having a helicopter view of what is my colleague, if they're reacting in that way, is there a reason for it? And having a bit more space and allowing that space just to work through the process.
Wonderful. Thank you for sharing that conversation with us, Anna and Isra. So our next speaker is Thomas Kitchen. Is a consultant anaesthetist working in South Wales, and he's a director of Canopy, which is a mental health support service for health and care staff working in Wales. As well, he lectures at Cardiff Medical School, and he is going to share his reflections about how emotional well-being relates to his performance and his behaviour. So welcome. Thomas, again, is not able to join us in person, but has shared his reflections with us via a pre-recording. Thank you.
It's a Tuesday morning. It's just after breakfast. It's sunny outside. You've got an appointment to see a doctor in a clinic you've never been to, and a doctor you've never met. You're not entirely sure what's going to happen, but you do know that you've got a 40-minute journey to get there, and yet by the time you get there, there probably won't be any parking to park the car. But this is important. It's something that you've been waiting for a couple of weeks. It's something that you've been thinking about over and over again ever since the GP made the referral. Even a weekend trip to see the sights of the Colosseum in Rome couldn't take your mind off it. You're telling yourself that it's probably all right, it's probably nothing to worry about. Loads of people you know have had similar things and they've all been just fine. But it turns out that it's not. It's not all right. It's still sunny outside, and yet it's freezing inside. To feel is human. What is it that we want when we go to see our doctor? To get the help that we need, yes, but there's something more, right? We need to know that our story's been heard. We need to know that they understand our anxieties, our difficulties, our desires, our fears. And in these things then we stumble across the empathy conundrum. Empathy is something that lies at the core of the relationship between a patient and a doctor and a patient, between a patient and a nurse, a physiotherapist, a podiatrist, a social worker, a healthcare assistant, a midwife. Empathy is the currency of human connection, of care, and of being cared for. Empathy is something that we miss when it's not there. In 2013, the Francis Report, and 7 years later in 2020, the Ockenden Report, both investigated unnecessary deaths. They both recognised a lack of empathy as a contributory cause. So empathy matters. Empathy and the power of our emotional interactions drive a connection between us. Empathy matters. It mattered on that Tuesday morning. And it matters for each and every one of us. Yet here's the conundrum. What is the person that is caring for you, your doctor, meant to do with all of the emotion that is passing through their hands? Your concerns, your fears, your anxiety, your tears. You see, there were at least 20 other people in the waiting room on that sunny Tuesday morning. For me, there was only one doctor and nurse to see, but for the nurse and the doctor, there was patient after patient after patient, and with each patient then comes a friend, a son, a wife, a daughter, a husband, each one of them needing, expecting and deserving an empathetic doctor. To be kind, to be compassionate, to care, to be human. So what do you do with all of this emotion? What did I used to do with it? Well, I built a wall. And in some respects, this is what I was trained to do, perhaps partly driven by my personality, my education, my professional culture. I would try and block out all emotion, to dumb it down, to hide them away. And as I went through training, the challenges grew greater, and so I would build myself a stronger wall to hide behind, something more tough, something harder, thicker, higher, deeper, stronger, better tested. For much of my career, this is what I thought resilience was. But because of this wall, an impenetrable barrier to emotion, one that doesn't let any emotion through, then we start to become numb to emotion. There's good research to show that doctors start building this wall in the early years of their medical school careers, that as a construct of medical education, levels of empathy actually decrease as medical students progress through their training. There's also good evidence to show that in building this emotional barrier, we are able to block out, at least for a time, the difficult stuff that comes our way, the grief, the shame, the fear, the failure, the disappointment, the death. But all of this building comes at a cost. You see, this wall stands as a brutal and non-selective barrier. And in creating this barrier then to difficult emotions, we are unintentionally at risk of blocking out all of the good stuff, the good emotions, the happiness, the love, the transparency, the joy, the humanity, the empathy, the building blocks of connection. Now I call it a wall, perhaps you call it a mask, perhaps it's an outfit, a bucket, perhaps an island. But the real problem with my wall is that all walls fall down, no matter how strong, how high, how wide, or how well tested. At some point you will be struck by a blow that is powerful enough to knock over your wall, fast enough that you didn't see it coming, or sustained enough that it just grinds it down. And behind this wall is all of the unprocessed and often unfelt emotion. And this time it hurts. And it all comes at once. We can't get rid of emotion. It's part of us. It's core to our humanity and essential to the formation of connections between us of patient, doctor, friend, partner, wife, husband. And so if we can't ignore it or hide it away, then what should we do with it? Well, we've got to learn how to use it, to understand and to know ourselves, to understand and know our emotions. There's much written about how we might work to increase our emotional intelligence, and for the last 5 years we've been working to share aspects of this published material with the medical students as they train and develop their skills as new doctors. What do we focus on? Well, we focus on 3 things. The first thing is to create genuine opportunity to practice and build reasons to notice our emotions, to pay attention to them, to recognise them, to practice them, to know them, to look for patterns in our behaviours, the good patterns, the bad patterns, even the ugly patterns. The second thing is to explore our emotional vocabulary. I wonder, how many words do you have in yours? Most adults, we have found, have around 10 readily used emotional descriptors. And when we consider the complexity and the colour of our lives and our experiences, then surely we need more than 10 words to be able to describe how we're feeling. The third is to recognise the importance of our personal values and how and why they drive our emotions and our behaviours. You see, it's rare that empathy is lost on purpose, but we know that it does get lost. It gets lost, it gets hidden away, it gets fenced in by individuals and by teams and by organisations. The key to unlocking it is in the gift of us all, that we might role model our true selves, our vulnerable, emotionally driven and empathetic selves. That we might take down the wall, take off the mask, empty the bucket and leave the island behind. That we might not hide it, but that we might learn to use it, becoming comfortable and recognise the power of vulnerability and making connections. To feel is human. It might hurt, but at least we know we're alive.
Thank you, Thomas, for that powerful reflection and a challenge, I think, to really be aware of how you on the other side as a carer are responding to things. Thank you to all of our speakers for sharing your experiences and reflections, the benefits of communication and emotional competence training to enhancing your work and the context in which you work in with your colleagues, with patients, with their carers and their families. We now have some time for questions, and we've been getting some wonderful questions coming in. Please continue to add questions to the Q&A. We'd love to answer them. Any questions that you want to direct to Thomas or to Isra, we can definitely ensure that we share those with them and get a response after the webinar. So please do feel comfortable to include those as well, and we'll ensure that those responses come through. So I'd like to start off by just directing a question, I guess, maybe to Moana, if she's comfortable. Given what we've heard from all of our speakers and given your own experience of training and seeing the enormous benefit and impact of having time to stop and reflect and learn these skills, why are these not being integrated within training more broadly? Are you able to share some of your reflections on that, particularly in the Kenyan context?
Yeah, thank you, Jam. So I think one of the challenges I've experienced as a person regarding this training is many of the health workers, many of the managers are not aware of the importance of this training. So it takes a lot of time to build that awareness on the need of this training. And one thing with our participants, when they are invited to come for this training, the question they ask themselves is, what am I going to learn in communication? I've been communicating all along. I've been communicating since I was born. So what is this a new thing that I'm going to learn in this training? So many of them feel like as a health worker, there's that assumption that you are supposed to know how to communicate, how to handle emotions. So there's need a lot of awareness on the importance of this training and these skills. And in Kenya, we have made a good stride because we have been able to engage the MOH, the Nursing Council about this training. And early this year, this training was accredited by the Nursing Council of Kenya. So anytime now I train participants on these skills, they get CPD points. And the Nursing Council is very keen for us to have this training on board in the nursing curricula. So those are the steps that I'm currently working on to see that this training is embedded into the curriculum so that by the time the nurses are coming out, they are good with technical skills as well as also emotional competence. Yeah.
It's fabulous, and well done too for progressing that. That's an enormous step and a wonderful opportunity for nurses in Kenya to have that, and other healthcare workers to have access to that. There's a wonderful question here by Rita that I'd like to share, and maybe Anna, you might be comfortable to answer. Sometimes when we get in touch with our emotions, we can discover difficult experiences or feelings. Sometimes people protect themselves from the emotions of others by not engaging properly with an awareness, whether consciously or subconsciously. Do you recommend applying this model together with professional mental well-being support for health workers? Would you like to answer that?
I have answered her directly, because I mean, it's a great question, and I've suggested that she gets in touch with Thomas, because this is exactly what he does. He is running a mental health support group for healthcare professionals in Wales, and he has this model as a background, and a lot of other things as a background as well. So I'm going to share with her the contact to Thomas, and let him answer that, because it is possible. But the good thing is to talk to somebody who is doing it to see what kind of experiences they have with it. So, and if I can just say one more thing about Thomas's very powerful message. Mona wrote me this morning and she said, I'm having a training with registrars in Nairobi next week. Do you think we can use Thomas's message there? And I have asked him, and I think it's a really, really good start for a training of doctors. And if anybody else is interested in that, let us know, and we will ask Thomas directly whether this one can be used. It's very seldom that you hear somebody speaking so profoundly, deeply about what the problems are and what the needs are, I think. So, okay, more directly to questions.
I just wanted to ask a question too, and maybe one of the other speakers might be willing to answer this. Obviously, one of the key elements of this model is that reflective, self-reflective aspect, which is a part of learning that people are not always as used to doing, is stopping and actually asking questions of themselves and the way that they interact and how they manage different situations. So my question to either Nancy or Florence perhaps is, how challenging is that aspect of the training for you personally? And how do you work through that process? Is it helpful to do it within a group setting, or have you found it helpful to do it individually, self-journaling? How do you manage that? Because that is a very challenging aspect, I would imagine, of this training. Florence, would you like to start that?
Nancy.
All right.
Nancy, go for it.
Okay, Nancy.
Nancy has done it herself, so I think she was eager to speak.
Sorry, Nancy, please you start, and then we'll invite Florence as well after.
So what I've learned is that actually when you do it, you do reflective daily, truthfully, because we are able to be truthful to ourselves. You'll discover how you communicate and the areas that you need to learn. And these areas help you now to communicate well, being aware of the emotions that your communication generates to the other people. And these have been very, very helpful. And this is what, as the course recommend, I too experienced that this is the first lesson or the first start of learning to change. Because when you change yourself, when you recognize the need to change, people learn. So before you go to reflecting as a group, you need to reflect as you are, as a person, and look at how you treat others. Sometimes people treat the healthcare workers, treat people like workload. I have so many patients. you are not looking at them like humans. But when you look at them as human beings, not as workload, you are able to be empathetic, as Thomas was saying. You are able to empathize with what they are going through. You are able to understand their challenges, their fears, their pains, and you are able to help them. And this will come by reflecting daily, asking yourself, how did I do it today? How did I communicate with my colleagues? How did I communicate with my patients? How did I answer her when she asked a question? When someone was rude to me, did I take a step back or did I go automatic? You know, with time, you develop the skills of stepping back, you develop the skill of respectful communication, and you realize that the work becomes more satisfying. You enjoy to go to work, you look forward to go to work tomorrow, and people are helped, people are blessed. And we know that people relate to how you treated them, not how you treated the disease they came with, how you addressed them as humans. So reflection, self-reflection is key to learning and key to change, according to me. Thank you.
Thank you, Nancy. And that's such a critical thing that you said, that they were treated for who they were as humans, not for who they were in terms of the disease. And when they've come to you to be treated, often that becomes the priority within that health context. So thank you for that. Florence, did you want to add anything?
Well, Nancy has said it all, really. What helps me is the fact that I believe what Jesus Christ said, and he said, do unto others as you'd like them to do unto you. And then where he says, whatever you do to the least of this, you do unto me. So I have to consciously keep reminding myself of that. And I'm asking myself, this person has a little bit of God in them, a lot of God in them. How am I treating the God in this person? It's hard, it's not easy, but that's how it is. Thank you. But Nancy has said it all.
Thank you. Thank you.
Can we maybe go to the question and answer and answer some of the questions about emotions here?
This is one of the ones I wanted to actually address to you, actually, is one in terms of how you deal with frustration when you're working within a context where as a health professional, there's just so much demand on you. How do you manage those levels of frustration that sometimes come from that context? Would you like to address that?
I've been thinking for a while about addressing the first question that came here. May I do that instead?
Sure.
About
sure.
how can we manage our anger as we most of the time become frustrated due to overburden or due to others not doing their work properly?
Yeah.
I think, Nida, this is a great question. And this you learn by doing the work over time to become aware of what makes you angry, what happens when you get angry, how do you respond to others, what is it that triggers you, and so on. And once you become aware of this, and you'll find in the manual in part B, tasks that can guide you to how you do this. When you find out what triggers your anger and you start getting aware and you get some skills on how to deal with it, then these things will fall into place. And the other thing is, as we most of the time become frustrated due to overburden or due to others not doing their work properly. Now, one of the things that we say is, we usually we have a session that's called changing behavior, how people change behavior, and I usually ask people to put up their hands and ask an answer. How many here has tried to change other people's behavior? Everybody puts their hand up. And then I ask, and how many of you have failed? Everybody. So you cannot get other people to change their behavior. You have to work on your own and how you respond to that person, and how you work with that person so that she or he gets interested in doing things properly. Find the reason why they're not doing things properly. There's always a good reason. So we are teaching people to speak with the person rather than judging and saying, you're a lousy worker. Find out what's going on here, what's happening. And you find out that there is almost always a good reason. And then you can talk about that. You can use empathy, and the person will very, very often be interested in changing. I think, Mona, is there anything you would like to add to that, or is that?
All.
Huh?
And I'm saying, I think you have said it all, but yep. one of the challenges that the health workers share in the training is working with uncooperative colleagues. So that's how they label them. So when they find that their colleagues are uncooperative, then how they address them then leads to conflict. But yep. when they come to the training with awareness, learning to become aware, learning to recognize the emotions of the other person, learning to communicate in a manner that is constructive and respectful, they go back and try to put these skills into practice. And what they tell us is they are now able to handle these colleagues. They say they are uncooperative, and they learn to see that many of them, often they have issues at personal level that they're struggling with, and that spills over to the work environment. So they get to understand them and work with them in a manner that is supportive. Yeah.
Exactly. So basically, in a few words, they come with a lot of judgment, and they leave with a lot of questions and a lot more understanding how to ask for people's the reasons why people do what they do. And once they find out the reasons why people do what they do, they say, so that's why. Now that I can relate to. So then the judgment disappears, and there is communication instead of this judgment, this automatic judgment that is so poisonous to workplaces. It is so extremely poisonous. So this we address the poison and give them better tools to to solve the poison.
Along, I guess, a similar context of understanding what the other person's view is, there is a question here that comment that sometimes we fail to manage our emotions due to our background. So how can we solve this issue? Does anyone want to respond to that?
I think what we say here, due to our background, is usually a poor excuse not to start working. It's only statues who don't change, because our background. Without knowing your background, but if there's something you don't know, you can learn it. If there is something that is emotionally challenging, you can learn how to deal with it. So just saying, it's because of my background. We had this in the beginning. I can't solve conflicts because I never learned how, or I'm always not solving problems. They cannot be solved, or that wasn't very, very. Mona, help me.
Yeah, no, that's very true. I think many of our participants come in with this notion that this is how I was brought up. This is how I saw my parents solving conflicts, and that's how I've learned. But in the workshop, they learn an alternative way and a more constructive way to handle conflicts in a manner that is constructive. So, so the skills expose them to an alternative, positive way of dealing with conflicts at workplace, with conflicts with colleagues. So I think it's just a matter of them getting this training, learning to become aware of their emotions, and also seeing that there is an alternative way of handling issues compared to how we were brought up. But this is a question, I mean, this is a question that the participants raise it up, that we are behaving this way because this is how I was brought up. But at the end of the training, we see them acknowledging that the skills are working better for them.
Yeah, exactly.
Yeah.
And just following on from that, there is also a question of, you know, along the lines of your earlier experiences in life and how that impacts how you engage with other people, how you communicate, your perspective of your place, perhaps. Do you think that poverty by itself could affect emotional competence, is the question?
You know, that's such a general question that it's almost impossible to answer. In my experience, working in some of the really poorest countries in the world, that, you know, if people are so poor that they don't have enough to eat and they don't have, you know, then that's an issue. But if that's another issue. But if they are working as professionals, even if they are very poor, and they have the capacity to work as professionals within healthcare, then they can learn. That is my experience in all the countries I have worked. So yeah, one, I don't know if you.
No, I totally agree with your explanation.
Yeah. Yes.
Yeah.
Yeah.
Perhaps one of the other speakers might want to add to this as well. There's a question recognising that, as you have introduced one at the beginning, the enormous impact on healthcare workers. COVID exacerbated it, but it was already there in terms of the workloads. How do we manage burnout? How do healthcare workers, healthcare professionals manage this, and what are the skills that iCARE-Haaland model provides to address this?
Can I answer very quickly to that, because this is a big question. Please go and read the modules. There are 2 modules about this, one in the basic course, one in the follow-up course, and it's also a topic that we are suggesting that we could run a workshop on in the future. But sorry, Moana, I jumped in. You're muted.
That's fine, Anna. That's okay. Yeah.
Okay, so we'll move on to another. How can workers have more of a productive work environment when the supervisor does not demonstrate emotional support or intelligence? How do you deal with that when it's yeah, the leadership that is not encouraging you to work in a particular manner?
Oh, we've had some great examples of that in Kilifi. Moana, would you?
Yeah, I think that's one of the challenges that our participants share in the course, that dealing with the managers who have no emotional competence is next to impossible. But what we tell them, or what we teach them, is that you cannot change somebody's behavior if they are not ready themselves to change. But you can change the way you handle this, the way you handle your supervisor. And a supervisor who has been approached with respect, they will notice that and they will treat you with respect. And we ask them to go and apply this to their managers whom they feel are not respectful or they are not supportive. So they change how they handle their managers by recognizing them, appreciating them, and respecting them. And this changes the way they handle them. So the trick here is you can't change your supervisor, but how you handle them. If you handle them with respect, they will in return also respect you as a person. And that is what our participants share when they come for the follow-up calls. We ask them, how did this work with your manager? And they share very positive feedback about how the way they approach their managers has changed the way they treat them. Yeah,
exactly. So when they have these skills, I mean, one of the things we say to them is that you cannot change the others, but when you change your communication with the other person will change gradually. Change is a two-way system, and when you change, something important happens. I mean, the first course I had in Šiauliai in Lithuania, I had a formidable leader who stood up and told everybody else to shut up in the class. And she was Russian and a lovely lady, and I had to challenge her in class with all the other ones to listen to the one whom she was angry with. And I wish I had a video. I'll never forget this communication between the two of them, where I told the leader to please hold back and listen, and the other one to please hold back and listen. This was the fundamental beginning of a different change, a different way of communicating between leaders and sub-leaders. So, as facilitators, when you know how to manage emotions, you can really help make a difference in teams that are stuck in their way of doing things.
Just on that point too, there is a query about the comment about healthcare workers who themselves perhaps, again, it might have been a previous experience of having experienced trauma personally or culturally, war, abuse, and they may have trouble opening up through reflection. What extra care is needed within the training context to enable that safe space to occur for those individuals?
Maybe just to share from my own experience. I think when the participants, we build a relationship with them right from the beginning, when we introduce the cause, and then we meet them every month to find out how they are working on the reflections. So we build that safe environment with them over time. And by the time we are running these workshops, they are used to one another and they feel safe to open up. And I can share my recent training where one of the participants is a medical doctor, and she shared her experience of wanting to commit suicide. And she told the group that this is something that she has never told anybody, but she felt safe to share with the group that she at one point, I think 3 times or 2 times, she wanted to commit suicide. But through the reflections, she felt that it helped build confidence in her to be able to share before the group. So many of them, the environment is usually very safe, and we are not judgmental to anybody. They're free to share what they feel like sharing.
Yeah, I think this is so crucial, Mona, what you say there, that building up emotional safety. That's our rule number 1. That's where we start from the first workshop that we have, or the first meeting that we have. Emotional safety, where we listen and learn, we don't judge. And this is very powerful to so many of them. And they come out with strong stories. And there's so many strong stories about nurses who have injected water into the patients because they were so pissed off with the patient. And they can talk about this and how badly they felt. And, so many stories we could tell you. So we can provide this emotional safety. And at the same time, we have to bear in mind that neither of us is a psychologist. And what we can handle is limited when it comes to deeper psychology. And when I have had several situations where I've sensed that people have been needing something more, and I have been putting them in touch with a psychologist, where they have gotten more of the help that they really need. So it's very important that we know the limitation of our knowledge.
I might just take one more question, which I think, Anna, you might be able to answer perhaps in your wrap up. There's a question about how do you evaluate the outcome of this training? What kind of percentage of health staff who are volunteers and attend training in a hospital? And is there any research about the comparison of trained and untrained staff? do you evaluate the satisfaction level of the patients in these two groups of staff? Do you want to say something briefly, or will you address that later?
I'll say something briefly and then turn over to Moana, because she is working on this now. We have some limited research on that from the first group that we trained in Kenya, and also from groups in some of the other countries where I have worked, but not systematic research. This is action research where we have built on our experiences and improved practice, rather than contributed a lot to research. And this has been an active choice, but it's also too bad, because I wish we had done more research. So Moana is now doing that. Moana.
Thank you, Anna. So since over the recent past, I've been involved in training newborn care nurses across many hospitals in Kenya. And we have put in an evaluation aspect to this training. So what we are currently doing is using the self-reports that the participants evaluate themselves. And then we also interview them individually. And then we also interview their non-trained colleagues and non-trained managers who are working with these participants that we have trained. So currently I'm doing analysis on 2 hospitals where we piloted this training, and looking at the comparison between these 2 hospitals, what the participants themselves reported and what their non-trained staff reported, what their managers reported. And it's quite very inspiring to see the difference in these 2 hospitals, where one hospital, the training worked really well, and the other hospitals, the training didn't really work well, and trying to explore what are the reasons behind these 2 key differences. So I think this is work that we are currently analyzing, and we hope to share maybe in our future webinars. So we are keen to make sure that we evaluate this training process as we evolve with it. Yeah.
That's beautiful.
And just to add to this person who is asking about trauma, personally and or culturally, war, abuse, I don't think that, I mean, we are not skilled enough to deal with that. That needs people who are, who have much more, much deeper psychological skills than we have.
So I think we've had wonderful questions. Any of the questions that we haven't been able to answer, we will certainly attempt to do so later. But thank you very much for that wonderful discussion. Just firstly to say, we will provide the link, but the full iCARE-Haaland resources are on the Connect website. There is other resources, support resources, and other testimonies from others who have shared how the training has impacted on their work. Many from early trainee participants in the training who have now have gone on, like Florence and Nancy, who have gone on to do training themselves with their colleagues. So please do go later and check the site. And if you have any questions, you're welcome to communicate with us, and we can certainly connect you with the speakers. So before we finish up, I would like to invite Anna to share. There has been a question about the impact, and Moana has indicated how they're exploring it. But further, Anna, would you like to share about the impact of utilising the model within healthcare work and some of your results and conclusions?
Sure. So some results and conclusions from 17 years of using this model. First, I'd like to say that the core of the model is that we're introducing a culture of reflection within hierarchies, medical hierarchies, cultural hierarchies. The hierarchies can cause very difficult communication. And what we are introducing is awareness and respect and emotional competence that change how people communicate. That's sort of like in a nutshell. You remember this one that we saw in the previous one? And now we have also, Mwana has talked about her training and her research in neonatal care units in Kenya. Mwana, would you like to add something?
I think basically it's what I have already said. So we have ongoing work of this training on newborn care to improve the quality of care that we give to our mothers. And these are some of the changes that the nurses are reporting, as Nancy has said, and Florence has said, that the training really increased their self-awareness to recognize emotions, see patients as fellow human beings, and they realize that when they communicate well, patients appreciate them in return, and this strengthens their confidence to use the skills more. And from this, this positive feedback from patients also helps to refuel their energy, not to from burnout. And also many of them, they're reporting that they're using the skills with awareness so that their untrained colleagues can see them as role model, and often they ask them to support. And then the main reason for this change is the direct relevance and applicability of the training to their daily work situations. So a great impact of the training, as you can see there, the sense of professional identity and strengthened core values, job satisfaction. And many of them report that despite the challenging work environments they are working, but now they can afford to go home feeling good about what they have done. So we are still looking onto these analysis, and we will share in our future webinars.
I think this one of the last sentence here is what I've heard across all the other countries as well. The work is the same, but we feel good when we go home because we've had many good experiences, and we haven't been judging like we were before. So this works. So what we can say here is that what is common to all the cultures is that emotional insights are central to participants across the cultures. We have put up some examples here. This you can read yourself in peace and quiet. Here is one of the managers in Kilifi that we have to read out. And she says, emotional intelligence has really helped me. It's a good thing. Most of the time you react automatically and become emotional. And at the end of the day, it doesn't solve anything. It worsens the situation. You become more frustrated, tensed, and more stressed. Something of which, when you are calm and handle it with a sober mind, it wouldn't have stressed you. So they are making choices based on what they have experienced, what they have seen is working. Now, a few of the skills I want to pull out, and the first one is listening with awareness. This person who said here, I'm a good listener, or so I thought. We have those in all the courses. I think they were doing well. And once they start observing, they say, oops, no, I'm not a good listener. I need to do something here. So this is, once you get this as a reaction, we know we have triggered a curiosity to learn. And that's what we're after. One who says here, my journey to self-discovery has been interesting. It's amazing how much people can tell when given a listening ear. It's amazing. The second one is about handling patients with awareness, finding reasons behind the behavior. We noticed that a bit earlier, but this is about listening with the intention to understand. Really having the intention to understand, not just listening sort of like haphazardly. I want to understand. I want to. And then they are exploring also the emotions and finding the reasons for the behavior rather than judge, blame, or dismiss. Here's one who says, now, I'm far kinder to myself after I started this work. One who says, several who says they are more aware. Yes, I have started to really listen to my patients and colleagues in a different way. And I am more aware of people's vulnerabilities that lie behind the emotions. They're looking behind the emotions rather than stopping at the emotions and say, emotions are bad, and judge. Recognizing automatic reactions and taking a step back, we have talked about. There are many lovely examples of this that you can enjoy yourself. I think before I speak and hold back from reacting. This is what it's about. You speak and you don't react automatically, you hold back. Pay far more attention to how I communicate with colleagues. This makes a difference. There are two more issues here: recognizing insecurity and taking action to step back. Insecurity is something that affects all of us. And when you are not aware that you're insecure, this can be dangerous as a healthcare professional. You may make mistakes. And there are lots of examples of such mistakes being made. So once you understand the insecurity, this is really, really crucial. And the other one is recognizing and respecting the other person's perspective as well as your own. Earlier, many would judge the other person for what he was doing. And now they are asking, okay, what's the reason you're doing that? Let me listen to you. And then when they see the other person's perspective, they have a dialogue going. So this again is a huge change. And they learn this through the observation and reflection tasks and discussing in class. It's not an easy skill to get, but it comes with working over time. Now, the next one is taking responsibility to communicate better. I love this quote. Thanks to this course, I have learned a lot and have broken the barriers that are hindering me to communicate effectively. I have realized that I am the problem when it comes to communication. I have decided to have a change, and that change is me. You know, when the participant says this, you know, okay, you're home. You've done your job. That person will change and continue to learn. And finally, taking care of your own well-being is something that they do much more effectively now. And then one who says here that this is a lifelong learning, and this is what it is. I feel a heightened sense of awareness of my own emotions. I recognize emotions like anxiety and vulnerability and try to find the triggers and manage them. It's a lifelong learning as different situations can challenge me in different ways, but this journey of discovery is an exciting one. I think this is a very powerful one. It's an exciting journey. You have seen that you learn and you will continue. Because this is about being a better professional, being a better human being, being a better wife or husband. You know, this is lifelong learning. Okay, so to finish off, what we are saying is that there is a need for a paradigm shift. I don't know, I don't see the top line here, do you? You see the top line, okay. So there is a need for a paradigm shift to acknowledge and act on the need for emotional competence to be recognized, respected, and taught to healthcare professionals. Why is this so essential? We have been talking about for the last 1.5 hours, but many nurses and doctors, they quit service, and training institutions need to recognize professionals' human needs, to have their emotions acknowledged, respected, and taught as a resource. Not ignored and say, this is, you just have to cope with this. As Thomas was saying, the wall comes. What do the training institutions do about those walls? Do they let people take suicide or quit the profession, or do they do something about it? This is what's needed to be done. It needs to be taught as a resource to connect to patients and allow professionals to be more human to patients and to themselves. If we can say the important need is to change perceptions of emotions from being emotional is negative, it's a weakness, to emotion and emotions is a problem, to being emotional is a natural thing. Emotions is a research when you learn how to manage them. So this is the change from denial. I'm sure you're very familiar with denial, most of you. This guy in the sand, you've all seen him. He doesn't want to face up to the problems. And finally, our conclusions and opportunities, that emotional competence make healthcare providers able to treat themselves and patients with more empathy and compassion. That healthcare providers who are emotionally intelligent are more humanistic towards patients and colleagues, kinder to themselves, and can cope better with stress. They're better team workers, they're more likely to stay in the profession. But this training is not something that you do in a 2 or 3 day course. It requires time, it's not a quick fix. It takes effort and dedication. It's like every lifelong journey. And finally, let us just add that much more research is needed to investigate how these skills can be taught and evaluated and included in all medical education. So that is, with that, I will say thank you very much for listening. With this, one of my favorite pictures of Moana and Hisa, who is a senior trainer in Kilifi. We were out on the water to celebrate that we had finished the course. Thank you.
Thank you very much to Anna, to all of our speakers, and thank you also to all of you for participating and joining in the session today. I know we have gone over time. There's been a lot of interest and discussion. There's been a lot of questions also in terms of accessing these presentations, accessing the training, accessing resources. Please, if you haven't already, go to the Connect website. There is a lot of information there. There's also a contact to Anna if you would like to follow up directly. The recording of today's webinar will also be online. So please, if others were unable to join today, they are more than welcome. It will take a few days for this to get up online, but then once it is, please do share it with others who might be interested. And finally, before you go, please, we would love to hear more from you about the session. There is a very quick survey that we'd value your input. We're also exploring the possibility of further workshops looking at particular focus areas. And I'm just going to quickly mention them now so that if there are particular topics that you would be interested in, please pop it in the chat now. Recognizing managing emotions using emotional competence as an introduction, recognizing and managing stress and burnout. Burnout has come up using emotional competence, handling anger and conflict using emotional competence, dealing with death and dying using emotional competence. Or if there's any other aspects of your work that you feel would be valuable to explore through this model, please do indicate for us either in the survey, in the comment section, or in the chat. And we would welcome your feedback as we explore whether to provide some further workshops that are a little bit more focused on various aspects of issues that people want to follow through. So finally, thank you very much. Anna, you have a quick...
Just a quick comment to that, because this was an overview of what the model is, but our, I would say the gold mine of this work that we have done, which is available out there. We are happy to share with you some workshops where we go deeper into an issue, like we have done in the different courses in the different countries. But then we need you to tell us what is it you would like to learn and why. And then we can see what it is that we can do. So thank you very much, Jaume, and thank you for facilitating all of this.
More than happy to look at other opportunities to share with the community more broadly. But thank you for your time, and thank you very much to our wonderful speakers for sharing. And good afternoon, good morning, good evening to all of you. And we hope to see you online again another time. Thank you all.
Thank you.